I'm very excited to have our speaker here for the day, Dr. Keith Morse. Keith is a pediatric hospitalist and medical director of clinical informatics at Stanford Medicine. And his work is in operational and research informatics issues, specifically focusing on meaningful deployment of machine learning in clinical settings. So clearly a topic that many of us are thinking about when we're developing our algorithms. Keith serves on Stanford as a Stanford co-site PI in the PEDSnet organization, which is a 11-site pediatric research consortium. And Keith's academic roles include Associate Program Director for Stanford's Clinical Informatics Fellowship. And we're very excited to have Keith join us today in this research seminar. And Keith will be presenting on protecting adolescent confidentiality with NLP and implementation. So welcome, Keith, and please take it away.
Thank you all for being here. It's an honor to be able to be like this. I hope you are all here because you are excited about the topic or.
Keith, may I interrupt you for just 1 minute? It's a little bit hard to hear on Zoom. I wonder if it might be possible to mute the 1701 mic and then unmute your laptop mic. Perhaps that might be better.
How about now?
Much better, except there's a little bit of an echo coming from 1701 mic.
How about now?
Oh, much better.
But now. Can you hear me, Akshay?
I can hear you super. Yeah, this is much better.
You see that? It looks like you're unmuted. So
I just
I think Akshay is picking up on stuff.
You can hear me?
Yeah.
When we turn it all the way down, you can hear me? Okay, great. All right. Thank you for being here. As Akshay said, my name is Keith Morse. I'm a pediatric hospitalist, and I get to come to present to you today in my capacity as the lead for TDAP, which is our Translational Data Science at Packard group, our group that's focused on operational machine learning. If any of you in the room have teenagers or remember when you were a teenager, you may be familiar with the situation where a teen goes to the doctor and the doctor tells the parents of the teen to get out of the room. Usually before the awkward conversations and pointed questions between the doctor and the teen start, the provider will offer some reassurance of confidentiality. When I'm taking care of patients, my preamble goes something like, this is something that we do with all of our teen patients. We ask their parents to leave the room. Sometimes teens do things or have questions about topics that they would rather talk to a doctor without their parent present, so we ask everybody to leave the room. Everything you tell me in this conversation will be confidential. The only time that I would have to tell somebody about something in our conversation is if you tell me that you're going to hurt yourself or you're going to hurt somebody else. Other than that, everything stays here. Now, the problem with that preamble is that in many cases, it's an empty promise. And the reason is that keeping information confidential in a health system is shockingly hard to do. That's because it's a combination of the complexities of our current health system, improvements that we've made in interoperability and data exchange, as well as the fact that despite the fact that teens are growing in their independence, they still remain fundamentally dependent on their parents. But keeping this confidentiality is super important. Studies show that teens are more likely to seek care for mental health and sexual health if their anonymity from their parents can be maintained. But on a much more fundamental level, maintaining the trust between providers and patients is critical to effective care delivery. It is problematic if we have system-wide processes that make liars out of our physicians when they promise their patients anonymity. At Packard, and specifically within our IT department, we have put in a ton of work to develop processes and tools to help maintain this confidentiality. And one of those tools is what's going to be the focus of my talk today. But before we dive in, I want to talk a little bit more about TDAP. We aren't a lab or research group. We are an operationally funded group within the Children's Hospital's IT department that is tasked with identifying, developing, and deploying ML within clinical settings. For those of you who are familiar with Nigam Shah's group and their data science, we are sort of the runty cousin of them. We have less funding, but similar goals, similar ambitions. Because we sit within the hospital, we are primarily targeted or focused on identifying ML that can bring value to the organization. If you think about ML projects as existing somewhere along these two axes, we are very much interested in the things that score well along the useful axis. The tricky part here is that most of us have a pretty good sense of what counts as an awesome ML tool. Novel, creative, ambitious, it gets funding. There's something sort of universal about things being cool and awesome. It's much harder to figure out what types of tools are useful. And part of the reason is that useful is a hyper-local characteristic. What's useful to one nurse may not be useful to another nurse. What's useful on Tuesday may not be useful on Sunday. And so nailing down exactly what is a useful project is something that we spend a lot of time working on. We think about this as sort of called good use cases for ML. What is something that's actually valuable? So that is what I would like to submit to the AMY community as kind of our contribution today, is sort of thinking about our processes and insight for identifying useful ML tools, and then an example of what I would think is a useful application. So this isn't a methods talk. The ML here is relatively low on the awesomeness scale, but hopefully you will see value in more on the usefulness axis. So to start, our process for identifying good use cases starts with needs finding. And needs finding is just another word for finding the problem with which you hope ML can solve. This is taken straight from Stanford's biodesign playbook. And our take on who needs to be at the table to come up with a good use case is outlined in these three circles. So the first is somebody with ML expertise. This is the person who presumably would end up building whatever ML tool you need, and also would be able to provide a realistic understanding of what is feasible and is not feasible with ML. Often we get requests from people who think that it can park their car or do many things that it just won't be able to. The second bucket is the health system ML infrastructure. And these are the people who understand what types of models are capable or can be run within a health system, what types of data are available, what's the cadence of data availability. And then the final one is specific workflow expertise. So these are the sort of boots on the ground people who themselves likely know very little about data science or machine learning, but they are the front lines in whatever sort of workflow you would potentially be introducing an ML tool. If you think about sort of the number of people that fit in each one of these circles, I would argue that here at Stanford, for our ML expertise, we have an embarrassment of riches. We have all you. We're in the sort of dozens to hundreds of people who would sort of fit that category. Perhaps in other organizations, it's a handful. For the health system infrastructure group, I think there is one team per organization that really understands this. On the adult side, it's probably NIGM's group, and then it's TDAP for us on the children's side. We actually spend a lot of our time building out capabilities to expand our infrastructure, but it's something that we spend a lot of time fine-tuning. And then for the specific workflow expertise, there are hundreds to thousands of people who potentially could fit this role. As I said earlier, it doesn't have to have any, this role doesn't require any ML expertise. This is about knowing the process that you do, or knowing your job within the health system, and within a complicated organization like a hospital, there are thousands of these types of systems that potentially, or these types of workflows that potentially could work with an ML tool. So because there are thousands of these types of workflows, the next question is sort of, who is the right person to talk to? Who is the person who can articulate what the organization's problems are that you as an ML person would potentially be able to address and solve? Typically so here we have a general org chart. This org chart could come from any organization on campus: nursing, hospital security, compliance, parking, anything that has some sort of manager. And if you think about it, it's the organizational leaders who are typically interested in the types of things that ML can offer. So they are particularly interested in improvements in efficiency, decrease in errors, and they're the ones charged with making things better. So they are motivated to improve and change. The problem is that management typically doesn't know the details of exactly how their team executes on a day-by-day level. So when you talk about sort of who is the group that has the insights that are available, or that are applicable to what you potentially would be changing with an ML tool, the sort of folks who are embedded in the front lines have that type of insight. So what's so important about this is that, one, these folks are going to be able to potentially identify a problem that could be solved by ML. They are going to be able to ideate solutions and give you a pretty good idea of, would an ML solution solve this problem? And then most critically, if you end up developing a tool that then goes to affect these people's workflow, they are the ones who are going to have to embrace it in order for it to work. So having them as a sort of early participant in understanding the problem and the solution is critical. Okay. So then we've done this process of addressing doing needs findings with a couple of different groups at the Children's Hospital. We've talked to rev cycle, quality and safety, infection control, but I want to get back to our example about adolescent confidentiality, because I think that is definitely our most sort of mature product or project, and what we're going to focus on today. Any questions before I keep going? You guys are good?
Any questions? First question. So when you're talking about to have the depth of insight, don't you think they have also, why do they have the highest motivation to find it to solve the problem?
That's totally fair. I think it is not. It's probably an unfair generalization to say that they are not motivated, because potentially if there is something burdensome about their job and they want to automate it, they would benefit from it. I'm thinking more along the sense of, if somebody's job has been built around a sort of fundamentally inefficient process and they don't see it as inefficient, that's sort of their job. It may not be as much of a pain point for them as opposed to a manager who is interested in potentially redesigning the system so that they can remove those types of inefficiencies. Okay, so here we are. We are in a clinic. We have a teen and his pediatrician. They've kicked mom and dad out of the room, and they having their conversation. In the course of this conversation, potentially certain things come up, namely for our case here, details about mental health, sexual health, and substance use. Once the provider finishes the visit, the patient leaves, he documents their visit in a progress note. And this progress note, once it gets filed into Epic, becomes subject to two competing pieces of legislation that impact how it should be handled. So the first one is a federal law called the 21st Century Cures Act. This law was passed in 2016, but didn't come into effect until 2020. And one of the pieces of 21st Century Cures is that it mandates electronic access to patient records without undue effort. And the corpus of data, or the corpus of PHI that is includes patient notes. Most health systems have complied with this law using the patient portal functionality that Epic provides. So on the Children's Hospital, it's My Chart. On the Adult Hospital, it's My Health. And through that, Epic has enabled most of the compliance for this. So the sort of technical capability is there. The second piece is adolescent confidentiality laws, and these are state laws that prohibit providers from sharing information with the parent of a teen without the teen's written consent if that information pertains to certain topics. And those topics are the ones listed on the left. So mental health, sexual health, and substance use. These laws have been, this law has been around since the 80s. Most states have analogous laws. And the intention is to, one, encourage providers to, or excuse me, encourage patients to seek care for sensitive topics, and also to protect kids who are in the unfortunate circumstances of potentially or being harmed if this type of thing were to be made public. So the conflict here is that the 21st Century Cures Act mandates that we share the whole note. Adolescent privacy mandates that we don't share parts of the note. And it turns out to be really tricky to thread this needle. So this is an issue that is facing children's hospitals nationally. This is not just a Stanford issue. Nobody has a particularly good solution for it. Up until recently, our solution to this conundrum has just been to not share any adolescent notes. We just sort of, we can't figure it out, and so we aren't sharing anything. That's problematic, of course, because there's lots of benefits to sharing notes. We want people to have access to their notes. We want kids to take responsibility for their own care, teens to become sort of stewards of their own health. We want to encourage that type of behavior. So it's unfortunate that we have to limit access to the notes because of this conflict in legislative mandates. So the way that we've been tackling this is two phases. The first was led by Dr. Bedgood, who is one of our clinical informatics fellows, who now actually works for California Department of Public Health. And the first step is around nailing down exactly what we consider to be confidential information. California laws are vague in the sense that they are clear about what topics should be included, but precisely how you define what that topic means is actually really tricky. So example here is mental health is one of the issues. Depression is a mental health issue. If somebody is feeling depressed versus has been depressed versus is depressed versus is diagnosed and being treated for depression. Those are sort of a spectrum of terms that all relate to depression, but exactly where you draw the line to say one is considered confidential and one isn't is totally vague. So in order to provide a little bit of structure and clarity around this, Drew convened a group of stakeholders, adolescent medicine physicians, privacy and compliance, informatics, and our IT portal folks. And they sort of looked at the regulations and pulled together what they called a rubric, but it was basically a well-intentioned attempt to operationalize these confidentiality laws. It's not intended to be a legally robust document. It's more writing down what would you do if a reasonable provider were attempting to follow these laws. We then trained 5 physicians in this rubric and had them review 1,200 notes. And after reviewing the 1,200 notes, we found that about 21% of our teens have some form of confidential information. This is something that wasn't previously known. It's not great news for that adolescent confidentiality laws, because it suggests that that even though providers ostensibly are supposed to know this type of information still has a fair amount of seepage into our notes. In terms of looking at what type of information we found in these notes, so it is, at least for our patient population, it's predominantly a mental health. So we can see about 12% of our notes had some reference to mental health. We could sort of think about both our patient population and our overrepresentation of subspecialist care that may distort these numbers relative to more traditional health systems. But these are the breakdown of what we saw, and then you can see the types of things that were identified along the right. Next step is, as you can probably guess, this is where the NLP, the automation comes in. How can we identify this stuff without having to do manual review? This was led by Naveed, who's one of our second-year fellows, and Connor, who is our data scientist within the Children's Hospital, and then support from Ethan, who is a PhD student in Ning Shah's lab. So we started with the corpus of 1,200 notes, trained an NLP model, and then the thinking with this model was to use it as a retrospective audit and education tool. So in a perfect world, we would of course have a tool that automatically redacts confidential information from notes. That would be sort of the ideal. But the legality of changing the medical record from what a physician has written based on what an algorithm thinks it should say is a huge leap in faith for what we would, the power and credibility we give to an algorithm. And we are miles away from that. There's not a chance that they would let us touch the notes that have been written by a physician. So the sort of path that we have for implementation is as an education tool, and I'll get more in detail in terms of how we went about that. You guys doing okay if I keep talking? Any questions?
Yeah, maybe one quick question. So I'm trying to like understand this problem a little better, and I just have a little perspective on this. But if a patient that a team comes in and then they have like a artist go written and they go home, is it not enough to just like make sure that they're the only people that know like the password and username for like my health, and like don't like maybe make that while they're there and then don't? Or is that still a concern because you're worried that the parents might like force the child to like tell them the password?
Yeah, great question. So
before answering the question, do you mind just repeating it?
There are, when somebody, so we consider teens to start at 12. When you're 12, you get your own MyChart account, which means that there's a separate account created for the teen, and those teens have special access and special notes that the adult account doesn't. The tricky part is one, we know that something like 60% of our teen accounts, so the ones that are supposed to be for teens, are in fact accessed by parents. And that's partially because we don't do a good job of setting up accounts with new emails, because often we pull the parent's email and have that be the account. But because that was the email that's been associated with the patient since they were 2, and so we use that as the login, and then they can reset the password. In most cases, we don't think it's nefarious. Parents aren't being sneaky. They're just trying to log on. They're just trying to get access to the records. The app can be kind of clunky, confusing. We know the parents have access. So the best approach would just be to sort of not share. And the way we do that, the way we sort of manage it, because although we don't want to share the information, we still want to record it. So being treated for STI or being treated for depression is part of your medical history. And so we have what we call a confidential note type. And so the process that we encourage the providers to use is you write a main progress note for the non-confidential things. That's what primarily is used for billing, and that's what gets shared with the families. And then there's a confidential note type that only gets used to document the confidential stuff, and then we can just wall that one off. So we just don't share confidential information, or excuse me, we don't share the confidential note type. And that's sort of the secure approach to both recording information, but hopefully separating it. Just to sort of like give you a flavor of how painful this actually is, notes are one piece of it, but every other type of information potentially also could give clues to somebody. One, billing information. If people get bills, there is almost nothing we can do to stop bills from leaking information. Medications and problem lists. So there are certain medications that are very clearly related to these types of confidential information. We can block some of them, but there are some that are both used for things that are confidential and not used for things that are confidential. And then problem list items. So having a diagnosis of depression in your chart, you can see your problem lists in your chart. And so if it ends up as a problem list, that is also something we filter. But the things that are structured are much easier to filter out, and that's a lot of the processes that we've done so far is doing the filtering out the structured things, but the unstructured thing is much trickier, as you all know. Great question. Good. Okay. Okay. So we need a model to do this. So model that Ethan and Connor were able to come up with. We used the 1,200 notes. That was from 2016 to 2019. 2 components. One is a sentence level component that's 10 tokens, TF, IDF. And then we take those scores, and the distribution of those scores is fed into another logistic regression that serves as our note model. Performance for this on our training data set was relatively reassuring. We were concerned though. We finished this in about 2021 or no, 2022, and we were concerned because we have gone a lot of effort to encourage providers to use that confidential note type that I was talking about, and that came out in 2020. And so our concern was that providers' documentation habits would have shifted substantially in the intervening 3 years because we have encouraged them to start using this confidential note type. So we wanted to reassure ourselves that it would perform reasonably well in the current state of documentation practices. So we did a validation set that was pulled from 2022. We had the same group of physicians review it and score the notes for presence or absence of confidential information, and it performed reasonably well there.
A quick question. If some of these notes that are confidential, how do these decisions?
So these are all progress notes. So like you have access to them via like the Star OMOP DID notes would have these in there. The confidential note type, I don't think gets included in Star OMOP, so I don't think you have access to that. But like the types of things that we were looking at here, so we were, because we're in the hospital, we don't work off Star OMOP, we work off Clarity. But the same note would be available to you. It just wouldn't be annotated, because like we annotated the ID'd one, the non-scrub one.
They want to be identified.
You mean the notes that you would have, or the?
Yeah, there's the notes for the training.
No. So one of the perks of working within the hospital is that we just get access to the notes. So this is considered, so we have an IRB for this work, but this is considered sort of QI because we are working to improve a process within the health system. And because we all sit within the Children's Hospital IS department, we just pull the notes out. So the expectations in terms of what types of notes we use changes a little bit. Okay, so yeah, have the model, and then the question is sort of, oh, and here's what it shows. So this on the left side here, we have some synthetic text. The advantage of using the two-component model with a sentence level and a note level score is that we can not only surface notes that are considered high risk, but we can highlight the chunks of the text that are likely to be high risk, and that makes review of the notes by a physician or some other reviewer much faster because they can dive in right into where the problem is. And then the text on the right is real examples of stuff that was highlighted as problematic. In terms of how we implemented this tool and continue to implement this tool, we took advantage of an ongoing effort within the Children's Hospital to update providers' note templates and documentation practices. There's a team that is charged with going around division by division and helping groups update their note practices to reflect both new E&M billing codes and some improved functionality that Epic has offered to help speed the process of making notes. So we were able to tag along with this group and include a portion about adolescent confidentiality and the sort of the new realities of note sharing that are now present because of 21st Century Cures Act. So we did a little bit of education there. Before we went into these sessions, we pulled the division's notes back a certain period. I think we did a month, and then we ran the algorithm to identify who is in this division having problems with their documentation practices. And then the goal was to be able to take that information and provide it to the divisions and provide it to individual providers to let them know that potentially they are documenting too much confidential information relative to their peers. This was so this is an example of when we did the rheumatology division. So you can see the light blue notes tell us how many notes the provider is writing. I think it's in a month. And then the dark blue is what percentage of those notes do we consider to be problematic? You can see that it looks like provider O has the highest proportion of, or the highest number of problematic notes. And so we're actually able to look into provider O's notes, and it turned out that he or she had a note template that was pulling in social history, and the social history often had some component of information that would be considered confidential. So by updating his or her note template, we're able to resolve this issue. And this is the sort of thing that is ongoing. We've got about a dozen divisions behind us, and it's going to take us 2 years to finish the rest of the divisions. But it's something that we're sort of slowly doing. And the plan is that once we are able to do sort of the first round of education, we'll be able to go back to the divisions that have had the training and see to what extent they are able to maintain these appropriate documentation practices. And this is also part of the process that made our organization feel comfortable turning on access to adolescent notes via our portal. So once we sort of did this, we did our education and we told providers about this problem, we felt it was the sort of risk-benefit analysis of, is it okay to share, shifted in favor of sharing our information. So once providers sort of go through this training, then we turn on the sharing of their adolescent notes. And so we haven't had any issues so far. We'll see if anything comes. And then we also had a conversation a couple of days ago with some social workers, because there is interest. They have the same problem we do with documenting confidential information that then gets shared. And so there's interest in figuring out whether this can get applied to social work notes as well. In terms of what is next for this algorithm, we are interested in seeing whether it works at sites outside of Stanford. And so we've got a multi-site study that is being set up. We have collaborators at UCSF, Valley Children's in Madera, and then Children's Hospital of Orange County, who are interested in seeing to what extent this algorithm can identify content in their notes as well. And that is all I have. Thank you all so much for your attention today. Really appreciate it.